Well, welcome everyone to the EKG case for the week of January 21st and 22nd, 2013. As you may know, January 22nd is the day that we're posting the case, and that's a Tuesday. And normally we do post these cases on Mondays, and that would have been January 21st, yesterday. Unfortunately, or fortunately, yesterday was a pretty busy day. It was Inauguration Day, and it was Martin Luther King Day, and a lot of stuff going on, so we posted it a day late. My apologies to all those people who were up late at night, staying up all night on Monday, waiting for the EKG case to be posted. And to all of you, I wish you a humble apology and also a request that you get a life. All right, so anyway, here we are, January 22nd. We've got an easy case. Last week's case was pretty tough. It was isorhythmic AV dissociation, and also we discussed the difference between AV dissociation and complete heart block, and it was a bit of a longer case, about 16 or 17 minutes. This week's case is going to be a lot simpler, but it is something that we really haven't talked about before, so for completeness sake, we're going to talk about this, and some of the viewers have requested this as well. This is an 86-year-old man that presented to the emergency department by ambulance complaining of chest pain and shortness of breath. Now, right off the bat, you know this guy is being admitted to the hospital. You don't even have to see him to know that, right? 86 years old. I have this general rule that the chance of a person being discharged home is 100 minus the age. You actually get 5 extra points for each chief complaint. So this guy's got about a 4% chance of being discharged home. Well, I'm just joking around a little bit like that, about that rather, but well, 86 years old, chest pain, shortness of breath, you know he's coming in, and you're thinking about some really deadly diagnoses here. You're thinking about acute coronary syndrome, you're thinking about pulmonary embolism, pericardial effusion, tamponade, maybe dissections in there. And in all of those scenarios, the very first thing you're going to do, even before saying hello to the patient, is to get a 12-lead EKG, right? And here's the 12-lead EKG. Again, this is not a terribly complicated case, but obviously you'll notice some tall R waves in the septal leads. You'll notice maybe little S waves out laterally, okay? And what else? There's a leftward axis, and that means this person, with everything, we've talked about this before, but this patient has a left anterior fascicular block and a right bundle branch block, and I'm tiptoeing around the most obvious finding that probably all of your eyes jump to right away. There is ST elevation in the anterior leads and also out here in the lateral leads. And in fact, there's Q waves in the septal leads. This person's having a big anterior septal and lateral STEMI. So this is kind of a no-brainer. There's no tricks here, but one other point that I did want to point out, you know that this person's got some ischemia going on as well. Take a look at the T waves, how straight those are. Obviously, you're picking up the ST elevation, but I did want to point out, once again, something that we've pointed out before, that when you see the straightening on the initial part of the T wave, even if that's all you see, you've got to worry about ischemia. In this case, the diagnosis is very simple because there's also ST elevation as well. So this is an anterior STEMI with a right bundle branch block, and I want to spend just a few minutes talking about a right bundle, because there is still some confusion about right bundle and right bundle versus left bundle. So let's go through some of the basics here with regards to right bundle branch block. So right bundle branch block patterns give you the tall R wave in your septal leads. And typically, there's a few different patterns that you might get. You can get an RS R prime type of pattern. You may sometimes get a QR type of pattern, or sometimes you get an RR prime type of pattern that looks like that. So there's various morphologies, but the key thing that distinguishes this from a left bundle, for those people that get left and right bundle branch mixed up, is that the right bundle branch block has a big R wave in V1 and V2. The left bundle, which I'll show you shortly, the left bundle has a big S wave in leads V1 and V2. So if you just keep those straight, you'll remember the difference. What else? The right bundle, to have a full right bundle, you should have a QRS complex greater than 120 milliseconds. All right. If it's less than 120 milliseconds, and all the other criteria are met, then it's just called an incomplete right bundle. In order to call it a full right bundle, it's got to be at least 120 milliseconds. And typically, a right bundle gives you a kind of a wide-ish S wave in your lateral leads. You'll notice it doesn't have to be deep, but you'll notice that there's kind of a wide-ish S wave. And I say wide-ish rather than wide simply because it is not always terribly wide, but it's just wide-ish. Anyway, there's a little judgment there, but there's an S wave that's just a little bit wide in your lateral lead. So tall R wave in V1, it's got to be greater than 120 milliseconds, and then that wide-ish S wave in your lateral leads is all diagnostic of the right bundle branch block pattern. The other thing that you normally notice, and this is really important, that you notice in a right bundle is that it's completely normal and in fact typical and expected to see a little bit of ST segment depression in V1, V2, maybe even out to V3, and the T waves tend to be inverted in V1, V2, and oftentimes in V3 as well. You really should not have upright T waves in V1 or V2, and probably, V3 can be plus or minus, and it's pretty expected to have some ST depression in V1 and V2. In fact, if you see isoelectric or certainly any ST elevation in V1 or V2, then you've got to really worry about this patient having a STEMI. Now, do you need any special criteria? We know that with a left bundle, there's these Scarbosa criteria that we've spoken about before. Right bundle, very simple. Any ST elevation in a right bundle is always abnormal. I'll say that again. Any ST elevation in a right bundle is always abnormal. When a right bundle patient develops a STEMI, what do? They develop ST elevation. All right, so here's a piece of cake, easy. A right bundle patient with an acute anterolateral STEMI. There's ST elevation one in AVL, and then out here in the anterolateral leads, you've got ST elevation, and that means that this person's got a STEMI. What else? Here's another example. Here's a patient with that RS kind of R pattern in that V1, and it's more noticeable in V2. You got that little hitch right there, but and there's really no Q wave out here. Let me go back for a second. In this case, you've got the QR pattern. This person's already developed Q waves in those septal leads, and in this particular case, the patient hasn't developed Q waves, not much Q waves yet, but you see ST elevation in V3, V4, V5. This is an acute anterolateral STEMI, and the patient's got evidence of an old inferior STEMI here as well. So it's really easy. When a patient's got a right bundle, any ST elevation is considered abnormal, and you're going to worry about the STEMI. If we go back to that 86-year-old patient that we saw, there's already some Q wave development in your septal leads, and there's ST elevation V1, V2, V3, V4. There's that straightening in V5, which makes you concerned about lateral involvement. There is lateral involvement in 1 in AVL. So this person's got an anterolateral STEMI. And again, any ST elevation, I'm saying this over and over because people sometimes forget, any ST elevation in the presence of a right bundle branch block has to be assumed to be abnormal. If they're having chest pain, you worry about STEMI. Now, switching over to left bundle for just a moment, the reason that we need special criteria, those Scarbosa criteria in a left bundle, is because it's completely normal in some leads to have ST elevation. For example, in lead V1 and V2, it's normal to have ST elevation. Typically in lead V3, in this particular EKG, it's kind of isoelectric, but typically in V3, you have a little ST elevation, and also in the inferior leads. The bottom line is anytime you've got a QRS that mainly points downwards, it's typical to have a little ST segment elevation in a left bundle. Same thing applies to pacemakers. Anytime the QRS mainly points downwards, it's typical to have a little bit of ST segment elevation. Take a look up here. ST elevation in that lead, there, everywhere that QRS mainly points downwards, it's normal to have a little ST segment elevation. So when you've got a left bundle or a paced rhythm, you need special criteria to figure out whether the ST elevation is normal or not. But in a right bundle, it's completely normal to have a little ST depression, but you should never have any ST segment elevation in a right bundle. Any ST segment elevation in a right bundle is considered abnormal. And because of that, you don't need any special Scarbosa criteria or anything else in the patient with the right bundle. And again, the other thing I want to remind everybody is it's normal to have some ST depression and T-wave inversions in V1, V2, and V3 in a right bundle, but really you shouldn't have ST depression in other leads, okay? So ST elevation in a right bundle in any leads abnormal. ST depression in a right bundle is expected in V1, V2, V3, probably not in the other leads though, all right? So hopefully that clarifies things a little bit with the right bundle versus the left bundle, and also some of the ST changes and the T-wave changes in a right bundle. And here's a question to think about for next week. We'll go through this next week. The right bundle I mentioned will give you that QR pattern in V1, or the RSR pattern, or the RR pattern. Bottom line, there's a tall R wave in V1, but there's a handful of other conditions that also produce a tall R wave in V1 that you've got to know about for the purposes of your differential. And next week, when we do the EKG case next week, we're going to talk about some of the other things that give you a tall R wave in V1. Be thinking about it in the meantime. Until next week, I hope you have a great week. I'll talk to you later. Bye for now.